Imagine your body like this really well-built ship, you know, sailing smoothly. But sometimes there's this unseen storm brewing deep inside, this internal battle that can really shake up daily life. That's sort of what it can be like living with inflammatory bowel disease, or IBD. Okay, let's unpack this a bit. IBD isn't just one single thing. It's more of an umbrella term, right? And it mainly covers two specific, distinct conditions that often get confused: ulcerative colitis and Crohn's disease. So today, our deep dive is really all about clarifying those key differences and actually some surprising similarities too. We want to give you a comprehensive understanding, but without that feeling of information overload you sometimes get. Our mission really is to break down the what, the where, the how, and maybe most importantly, why it matters for both of these conditions based on the material we've looked at.
Yeah, and what's really striking here is just how chronic these conditions are, how inflammatory, and honestly, how life-altering they can be for people. Both of them fundamentally stem from the immune system kind of, well, turning against the body, specifically in the gut. So our goal today is to equip you with that foundational knowledge about both conditions and, critically, how they differ. Because that distinction, it's absolutely essential for understanding their impact and, really crucially, how they're managed day to day.
Okay, so let's start broad then. What exactly is inflammatory bowel disease?
Right. So at its core, IBD refers to chronic inflammatory conditions, and they affect the gastrointestinal tract, basically, your entire digestive system from top to bottom.
And while, chronic inflammatory conditions might sound a bit clinical, the actual impact is often quite severe, isn't it? Like intense abdominal pain, diarrhea.
Exactly. Those are common symptoms, yes, but their severity and persistence in IBD are often really underestimated by people who haven't experienced it.
And the mechanism behind it, you mentioned the immune system.
That's the key.
Yeah.
This isn't just simple inflammation. It's driven by a cell-mediated immune response happening in the gut. It signals that the immune system isn't reacting normally. It's an abnormal reaction.
Okay, so the immune system is reacting abnormally. Why?
Well, that's the million-dollar question, really. We don't know the precise trigger, the exact etiology, but we understand it's an inflammatory disease where the immune system goes haywire, probably in response to environmental factors in people who are genetically predisposed. It seems to be this really complex mix of things. Genetics, maybe issues with the gut lining, the epithelial barrier not being strong enough, and maybe problems with the immune defenses themselves. It's multifactorial.
A perfect storm, almost.
Kind of, yeah. This intricate web leads to that persistent chronic inflammation we see. And it's just so vital to keep emphasizing, even though they're both under the IBD umbrella, ulcerative colitis and Crohn's have very distinct characteristics. They're unique battles, going back to your ship analogy.
Okay, good point. Let's tackle the first one then. Ulcerative colitis, or UC, what's the story there?
So ulcerative colitis is a chronic inflammatory disease, and it causes ulcers, hence the name. It primarily starts in the colonic mucosa.
The mucosa being the inner lining of the large intestine, right?
Yeah, exactly, the very inner lining. And location is key with UC. It almost always begins down in the rectum, the final section of the colon. From there, it can spread upwards, proximally, sometimes involving the entire colon, but it does so in a continuous fashion, no gaps.
Okay, continuous spread. And you said the mucosa, so it doesn't go deeper.
Generally, no. That's a major distinction. The inflammation in UC affects the mucosa and maybe the layer just beneath it, the submucosa. So it's considered superficial inflammation. It doesn't typically penetrate the full thickness of the bowel wall. And you often see this really sharp border between the inflamed area and the normal tissue, like a clear line.
Interesting. Are there visual signs a doctor might see?
Yes. During a colonoscopy, besides the obvious redness and ulcers, in severe cases, you might see something called pseudopolyps. Now, these aren't cancerous polyps or anything. They're more like swollen, inflamed bumps of the mucosal tissue that have reacted strongly to all that inflammation.
Okay. And symptoms. What would someone typically experience?
The absolute hallmark symptom of UC is attacks of bloody diarrhea. That's really characteristic. But the intensity and duration of these attacks can vary wildly. People can have flare-ups and then periods where they feel perfectly fine, asymptomatic intervals.
So it comes and goes?
Often, yes. Other common symptoms include urgency, that sudden, desperate need to go to the bathroom. Tenesmus is another one.
Tenesmus. That's the feeling like you need to go, even if you've just been, right.
Exactly. Even when the bowel is empty, it's very uncomfortable. Abdominal cramps are common too, and obviously seeing blood and mucus in the stools. And sometimes the inflammation is so significant it causes systemic symptoms, things like fever or weight loss, showing it's affecting the whole body.
And you mentioned it's not just the gut.
right? UC, like Crohn's, can have what we call extraintestinal manifestations, symptoms outside the GI tract. Arthritis, affecting the joints, is one common example. Skin problems, eye inflammation can also occur.
Wow, okay. So how do doctors confirm it's UC and not something else?
Diagnosis really hinges on colonoscopy and biopsy. You need to see it and sample it. The colonoscopy lets the doctor look directly at the colon lining. For those signs we talked about, the redness, the swelling edema, the loss of the normal blood vessel pattern, that fragile, easily bleeding mucosa, we call it friable, and the ulcers. Then the biopsies, the tissue samples, are examined under a microscope to confirm the inflammation is characteristic of UC and, importantly, rule out other things.
Like infections.
Precisely. Infectious colitis like amoebiasis or certain bacterial infection like bacillary dysentery can sometimes look similar initially. So stool cultures are essential to rule those out. And of course, the biopsy helps differentiate it clearly from Crohn's disease, which looks different microscopically.
Are there serious complications to worry about with UC?
Yes, definitely. One of the most serious is toxic colitis, sometimes called fulminant colitis. This is where the ulceration, which is usually superficial, actually extends deeper right through the bowel wall transmural extension. This can paralyze a section of the bowel, causing what's called a localized ilesis, and it can lead to peritonitis, inflammation of the whole abdominal cavity lining. It's a genuine medical emergency. The risk of the colon perforating, basically tearing open, is high, and that dramatically increases mortality. Urgent treatment, often surgery, is needed.
That sounds incredibly serious.
It is. And then there's a long-term risk. People with UC have an elevated risk of developing colon cancer compared to the general population. The risk increases the longer someone has had UC and how much of their colon is affected.
So what does that mean for patients?
It means regular surveillance is absolutely crucial. Usually this involves having a colonoscopy every, say, 1 to 2 years, starting about 8 to 10 years after their diagnosis, to look for any precancerous changes called dysplasia. Catching it early makes a huge difference.
Right, ongoing vigilance. Okay, that gives us a really clear picture of ulcerative colitis. Shall we move on to the other main player, Crohn's disease?
Let's do it. Crohn's disease, or CD.
How does this one differ? You mentioned UC is superficial and continuous in the colon.
Right. Crohn's is defined as a chronic transmural inflammatory bowel disease. That word transmural is the first massive difference.
Meaning it goes through the whole wall.
Exactly. All layers of the bowel wall can be affected, from the inner lining right through to the outer layer. This deeper inflammation is a key feature of Crohn's, and the location is another huge differentiator, unlike UC, which is limited to the colon.
Crohn's can be anywhere.
Pretty much anywhere in the GI tract, from the mouth all the way down to the anus. Anywhere along that path can potentially be affected by Crohn's, though statistically, the most common spots are the very end of the small intestine, the distal ileum, and the colon. Often both are involved, which we call ileocolonic Crohn's.
Okay, anywhere. But does it affect it continuously like UC?
No, and that's the other really characteristic thing about Crohn's. It typically affects the bowel in patches. You'll have areas of quite severe inflammation, and then right next to it, a stretch of perfectly normal, healthy bowel tissue, then another patch of inflammation further along.
Ah, so it skips areas.
Exactly. We call them skip lesions or skip areas. This patchy distribution is very typical of Crohn's and quite different from the continuous inflammation seen in UC.
And visually or pathologically, what does that transmural patchy inflammation look like?
Because it goes deeper, you can get things like deep fissures. Think of them like long, deep cracks or ulcers penetrating into the bowel wall. You also see inflammation in the crypts, those tiny glands in the lining, and sometimes these can develop into abscesses, pockets of pus within the bowel wall or even outside it. When a doctor looks inside during an endoscopy, the lining can have what's called a cobblestone appearance.
Cobblestone.
Yeah, because you have these deep ulcers or fissures cutting through swollen, inflamed mucosa. It can look bumpy and irregular, like an old cobblestone street. And just to reiterate a point, about 80% of people with Crohn's have involvement of the small bowel, usually the ileum. That's much less common in UC, which is almost exclusively colon.
Okay. What about symptoms for Crohn's? Are they similar to UC? Bloody diarrhea?
Sometimes, but bloody diarrhea is actually less common as a primary symptom in Crohn's compared to UC. Often, the initial things people notice with Crohn's are more like chronic abdominal pain, sometimes fever, loss of appetite, anorexia, and quite significant weight loss. Diarrhea is common, but it might not be bloody.
And because it's transmural and patchy, does that lead to different kinds of complications compared to UC?
Absolutely. The complications really highlight the differences. Because the inflammation goes deep and is patchy, Crohn's patients are much more prone to developing those abscesses we mentioned, those pockets of infection. They're quite common. And fistulas. This is a major complication unique to Crohn's.
Right, you mentioned those earlier. What are they exactly?
Fistulas are basically abnormal tunnels or tracts that form. Because the inflammation goes right through the bowel wall, it can burrow into adjacent structures. So you might get a tunnel forming between two loops of bowel, or between the bowel and the bladder, or the bowel and the vagina, or even right through to the skin surface, often around the anus. These occur in maybe 25% to 33% of patients, so a significant number, and they can be very difficult to treat.
Wow, that sounds really challenging. Any other major complications?
Yes, bowel obstruction is another frequent one. The chronic inflammation and subsequent scarring can cause narrowing of the bowel, called strictures, which can block the passage of food. And because Crohn's so often affects the small intestine, the primary site for nutrient absorption, malabsorption, is a big concern. If large sections of the small bowel are inflamed or have been surgically removed, the body can struggle to absorb essential nutrients, leading to deficiencies, commonly in things like vitamin D and vitamin B12, but also fats, other vitamins, and minerals.
Leading to weight loss and other issues, I imagine.
Definitely. Weight loss, fatigue, anemia, osteoporosis. The nutritional consequences can be significant. And just like UC, Crohn's can also have those extraintestinal manifestations, arthritis, skin problems like erythema nodosum, those red tender bumps, eye inflammation, and others.
So diagnosing Crohn's sounds like it might be more complex given it can be anywhere.
It can be. Diagnosis usually involves a combination approach. Colonoscopy is still key, especially if the colon is involved, and biopsies can show characteristic features. But because the small bowel is so often involved and you can't reach all of it with a standard colonoscope, imaging studies become really important. Things like CT enterography or MR enterography, special scans designed to visualize the small bowel in detail, are very useful. Sometimes older tests like Gerium studies are used too. And laboratory tests are crucial blood counts to check for anemia or infection, markers of inflammation like C-reactive protein, CRP, or fecal calprotectin, and tests to check nutritional levels.
And again, differentiating it from UC is a primary goal.
Always. The location, the pattern, skip lesions versus continuous, the depth of inflammation, transmural versus superficial, the presence of fistulas or granulomas on biopsy, all these pieces help distinguish Crohn's from UC.
You mentioned surgery earlier for UC complications. What about surgery in Crohn's?
Surgery plays a very different role in Crohn's. It's needed much more often. Estimates are around 70% of patients will require surgery at some point in their lives. But, and this is a huge but, surgery is not curative for Crohn's disease.
Not curative. Why not?
Because the disease can, and often does, recur, usually near the site where the surgery was performed, or even in completely different parts of the GI tract later on. Surgery in Crohn's is typically done to manage complications that aren't responding to medication. Things like persistent bowel obstructions due to strictures, draining abscesses, or dealing with intractable fistulas that won't heal. So it's about fixing a specific problem caused by the disease, but it doesn't eliminate the underlying disease itself. It's like patching a deep crack in the ship's hull. You fix the immediate leak, maybe replace a section, but the inherent structural issue that caused the crack might still be there, ready to cause problems elsewhere.
That's a really crucial distinction for people to understand. Surgery as management, not cure. Okay. We've looked at UC and CD individually in quite some detail. Maybe now is a good time to really crystallize those key differences side by side. Pull those aha moments together for everyone listening.
Absolutely. Let's summarize the main contrasts.
Okay, first up, location.
UC, confined strictly to the colon, almost always starting in the rectum and spreading continuously upwards. CD, can affect any part of the GI tract, mouth to anus, but most commonly the end of the small bowel, ileum, and colon, and critically, it does so in patches, those skip areas.
Got it. Next, depth of inflammation.
UC, superficial, affecting only the innermost layers, the mucosa and submucosa. CD, transmural, penetrating the full thickness of the bowel wall.
Bleeding.
UC, gross rectal bleeding is a hallmark symptom, very common.
Yep.
CD, less commonly presents with obvious rectal bleeding, though it can happen.
Okay, and those specific complications, fistulas and abscesses.
CD, common complications due to the transmural inflammation. UC does not typically cause fistulas or abscesses.
What about issues around the anus, perianal lesions?
CD, often associated with significant perianal disease, skin tags, fissures, fistulas around the anus.
Hmm.
UC typically does not involve perianal lesions.
How they look during an endoscopy?
UC shows uniform, diffuse inflammation spreading continuously. CD shows patchy inflammation with skip areas, often with that cobblestone appearance and deep ulcers or fissures.
And under the microscope, anything specific?
CD often shows granulomas, small clusters of inflammatory cells on biopsy, though not always. UC granulomas are typically absent.
And finally, the big one regarding surgery and cure.
UC can potentially be cured surgically by removing the entire colon, total colectomy, because the disease is confined there. CD cannot be cured by surgery, as the disease can recur elsewhere in the GI tract, even after resection.
That really lays it out clearly. So many distinct features.
It does. But it's also remarkable, isn't it, how despite all these fundamental differences in pathology and location, the initial symptoms, abdominal pain, diarrhea, fatigue, can sometimes overlap quite a bit.
Yeah, which raises an important question. How often does that initial overlap lead to diagnostic challenges? Or maybe even misdiagnosis early on?
It definitely can be challenging sometimes, especially in cases where the disease might be presenting unusually, or perhaps only involves the colon initially in Crohn's colitis. That's why, as we've discussed, the diagnosis often isn't based on one single finding. It relies on putting together the whole picture: the patient's symptoms, the endoscopic appearance, the imaging results, especially for small bowel Crohn's, and crucially, the biopsy findings. It's a combination approach.
Piecing together that puzzle, as you said. Okay, so we understand the differences. We know how they're diagnosed. Let's talk about managing these conditions. How do people live with IBD?
Right. Management. Now, even though UC and CD are different diseases because they both fundamentally involve chronic inflammation driven by the immune system, many of the treatment approaches actually overlap.
Targeting that common pathway of inflammation or immune response.
Exactly. The goal is usually twofold: induce remission, get the inflammation under control during a flare-up, and then maintain remission, keep the inflammation quiet long-term.
So what kinds of treatments are used? Can we categorize them?
We can. There's a sort of stepwise approach, often depending on the severity and location of the disease. For mild to moderate UC, and maybe mild Crohn's, particularly if it's just in the colon, drugs called 5-aminosalicylates, or 5-ASAs, like mesalamine, are often the first line. They are topical anti-inflammatories for the gut lining.
Okay, 5 ASAs for milder cases. What about flares?
For acute flare-ups, especially moderate to severe ones, corticosteroids, like prednisone, are very effective at quickly reducing inflammation. They are powerful anti-inflammatories. However, due to significant side effects with long-term use, they're generally used short-term to gain control, not for long-term maintenance.
Right, steroids are usually a temporary fix. What about keeping things calm long-term?
That's where immunomodulators come in. These are drugs that modify or dampen down the immune system's overactivity. Examples include azathioprine, 6-mercaptopurine, or methotrexate. These take longer to start working, but can be effective for maintaining remission and sometimes allowing people to get off steroids.
Okay. And I hear a lot about biologics these days.
Yes. Biologic agents have really revolutionized the treatment of moderate to severe IBD in the last couple of decades. These are generally proteins, often antibodies, that are designed to target very specific molecules involved in the inflammatory process. The first group were the anti-TNF agents, like infliximab or adalimumab. They block a key inflammatory protein called tumor necrosis factor alpha. More recently, we have other biologics that target different pathways, like vedolizumab, which targets gut-specific cell trafficking, or ustekinumab and risankizumab, which target inflammatory messengers called interleukins.
So more targeted approaches.
Exactly. More targeted and often used when older therapies haven't worked or aren't tolerated. And there are even newer options called small molecule agents. These aren't proteins, but small chemical compounds that can also interfere with specific immune signaling pathways inside cells. Examples include tafasitinib, upadacitinib, and ozanimod. They offer more options, particularly oral options in some cases.
That's quite an arsenal. Any role for antibiotics?
Yes, but usually for specific situations or complications. For instance, antibiotics like metronidazole or ciprofloxacin are often used to treat perianal Crohn's disease, fistulas, or abscesses. They might also be used in cases of toxic colitis and UC, alongside other therapies. But they aren't primary treatments for the underlying inflammation itself.
And surgery, we've touched on it, but just to recap its role in management.
Right. Surgery remains an important option, or sometimes a necessity for both conditions, but with those different goals. For UC, total colectomy can be curative, but it's obviously a major life-changing operation. It's usually reserved for severe disease, unresponsive to medication, toxic colitis, or high-risk precancerous changes. For Crohn's, surgery is for managing complications like obstructions, abscesses, or fistulas that medication can't control. But again, not a cure, as the disease often recurs.
So managing IBD sounds like much more than just taking medication.
Oh, absolutely. Medication is just one piece. Effective management involves ongoing health maintenance and supportive care. This is crucial.
What does that involve?
Well, several things. Immunizations are incredibly important. Because many IBD medications suppress the immune system, patients are more vulnerable to infections. So keeping up to date with recommended vaccines is vital. Things like the flu shot, pneumococcal vaccines for pneumonia, the newer shingles vaccine, recombinant herpes zoster, hepatitis A and B, HPV, and tetanus diphtheria boosters.
Makes sense. Protect against preventable infections.
Exactly. Then there's screening. We already mentioned colon cancer surveillance for long-standing UC, but there are other screening needs too. For example, patients who've been on steroids long-term are at risk of osteoporosis, so regular bone density scans, DXA scans, are often recommended. Also, some immunosuppressant medications slightly increase the risk of certain cancers, like skin cancer or cervical cancer, so regular skin checks and PP smears are important.
So it's proactive monitoring for potential side effects or associated risks?
Precisely. And then there's the day-to-day supportive care. Dietary management plays a role. Although there's no single IBD diet, it's often very individual, focusing on identifying trigger foods during flares and ensuring adequate nutrition. Stress management is also important. While stress doesn't cause IBD, it can certainly exacerbate symptoms for many people, so finding healthy coping mechanisms is beneficial.
It really sounds like a partnership between the patient and their healthcare team.
It absolutely has to be. As you said earlier, knowledge is most valuable when understood and applied. Managing IBD is typically lifelong. It requires ongoing monitoring, adjusting treatments as needed, and that close collaboration with doctors, nurses, dietitians, and other specialists. It's a complex, long-term partnership.
We have certainly covered a huge amount of ground today, really taking a deep dive into inflammatory bowel disease. We started by setting apart ulcerative colitis and Crohn's disease, walking through their very different characteristics, their symptoms, how doctors diagnose them, and the pretty complex landscape of managing them. It's become really clear that even though they share that IBD label and some treatments, they are fundamentally distinct chronic conditions needing careful, personalized, ongoing care. So what does all this mean for you listening in? Our hope is that this deep dive has given you a kind of shortcut, a way to become really well informed about these conditions pretty quickly, whether that's for your own understanding, maybe because you know someone living with IBD and want to support them better, or perhaps just to expand your general health knowledge. It's definitely a lot to take in, isn't it?
It absolutely is. And, digging this deep into the mechanisms and differences really makes you wonder, thinking about the future. How might a deeper, more nuanced understanding of the gut microbiome, that incredibly complex ecosystem of bacteria and other microbes living in our intestines, how might that continue to revolutionize our approach to these conditions? We're learning so much about its role in immunity and inflammation. Could manipulating the microbiome become a major therapeutic strategy in the years to come? Well, we've covered a significant amount today based on current understanding. The field of IBD research is just constantly moving, constantly evolving. New insights, new potential therapies are emerging all the time. There's always more to learn about the inner workings of that ship, as you put it.